I am going to show you a procedure of bipolar hemiarthroplasty. My preferred approach is antero-lateral approach. In the theatre setup, patient is kept in left lateral decubitus position. Side pose kept at the sacrum and anteriorly at the pubic symphysis level to facilitate complete flexion and extension of the hip joint. We have to position the post accordingly. While our manipulation of the limb, the ASIS should remain static. There should be no movement at the ASIS. There are many approaches to the hip joint. This is the posterior Moore's approach or the posterior border of the greater trochanter. This is the greater trochanter. This is the ASIS. These are the two main landmarks. This is the posterior Moore's approach. This is the Harding direct lateral approach or transgluteal approach. We can go through this approach and do modified Hardings also. Anterior to the greater trochanter is our anterolateral approach, which is in between the tensor fascia lata, plane in between the tensor fascia lata and the gluteus medius muscle. For this procedure, here I will stand anterior to the patient. This is anterior, this is cranial, this is caudal, this is posterior. Now I am going to make my skin incision anterior to the greater trochanter towards the ASIS. 10 centimeter skin incision. Now I am going to open the fascia lata. The clean cut in the line of our incision. We are going in between the tensor fascia lata and gluteus medius. I am gently dissecting in the plane between the tensor fascia lata and gluteus medius. We have separated our tensor fascia. This is the tensor fascia lata. This is the gluteus medius muscle. Now we are on the capsule of the hip joint, directly on the capsule of the hip joint. You can see this is the capsule which we are going to open in head-shaped manner. While giving a capsular incision, ask the assistant to keep the limb external rotated and then open the capsule. Capsule. You can see gush of fracture hematoma, as this is a 6 days old fracture. While releasing the capsule, ask the assistant to gently hyperextend the hip and external rotate the limb. Okay. I have opened the capsule in head shaped manner. I am releasing the capsule from the neck. I am keeping the omens over the greater trochanter. We have to release vastus lateralis in the anterior-inferior part of the greater trochanter. This is the lesser trochanter. This is the pyriform fossa. I am keeping 1 centimeter above the lesser trochanter. I am marking the neck. I am marking my neck cut. While doing the neck cut, I am keeping the limb perpendicular to the floor. This is the pyriform fossa. I am taking the neck cut from pyriform fossa to 1 centimeter above the level of LT. Your assistant should keep the limb in perpendicular position to the floor while giving our neck cut. After my neck cut, I am going to extract the head. There is a chance of lateral circumflex vessel injury in this approach, and also there will be superior gluteal nerve which will be traveling from posterior side above the surface of greater trochanter and travel towards, after supplying gluteus medius, travels towards tensor fascia lata. Now I am going to extract the head in the same direction of our capsulotomy. The gluteus muscle, gluteus minimus muscle, that we have to release. This gluteus minimus muscle most of the times merge with the capsule. Starting head, you can gently keep the limb on the table and external rotate and use a corkscrew. This corkscrew is very important tool for extraction of the head. Or you can extract using two Bowman spikes. In sclerotic burn, sometimes we have to tap the corkscrew. Now I have extracted the head. Measuring the head size, this is the perfect size, 45. So we are keeping the 45 size bipolar. Always keep smaller size if we are in between sizes. I have kept the mop in the acetabulum. I am taking the valgus entry. First I am towards the GT. After that, I am using the canal finder. I am directing towards the medial condyle. By keeping my one hand over the shaft of femur distally, I am directing my entry femur to find the canal. Now I am approaching the femoral canal. I am alkalizing the femoral entry, and then I am going to impact, approach. Gently giving 2 taps for this bone to expand while broaching. While broaching preparing the femoral canal, your assistant should hold the limb in external rotation, foot parallel to the floor. So this is the end point of our broaching. This serration should touch the calcar. I have done my femoral preparation from the anterior side, unlike the lateral and posterior approach, where we have to do our femoral preparation from posterior side. Bipolar processes. There will be head and socket. There will be 2 planes of motion. This is the stem. Now I am going for trail reduction. Now I am removing the mop from the acetabulum cavity, checking for any loose bodies. I am gently keeping the limb over the table. The socket, acetabular socket should lie, end of the acetabular socket should lie at the level of the head of the processes. That means we are correct in taking the neck cut. I am going to keep 5 to 10 ml of saline in the joint. Now your assistant should give traction, and then I am going to gently keep the head in the socket. Make sure that there is no capsule or soft tissue in the socket. Traction. You can see there is sound. That means our joint is reduced. After reduction, you should check for movements. Limb length first, comparing knee and both heel parts. Length disturbance in bipolar surgery, we should choose shortening rather than lengthening. Lengthening will cause neuropraxia of the sciatic nerve, so we should avoid that. Now I am going to dislocate it and then keep the cement. Always keep the cement for this bipolar. While dislocating, you can use the bone hook and ask the assistant to keep the limb in external rotation and traction.
Start.
The external rotate. Hip joint is dislocated. Now I am going to remove the process and fill the cement and keep the process again. Always use bipolar, cemented bipolar, as cemented hip arthroplasty shows better results than non-cemented. If you don't use cement, it will become tripolar. There will be additional movement at the shaft and the stem of the processes. So always use cement for the longevity of the implant. I have removed the process. Now I am going to prepare the bony canal with cement, a mop in the acetabulum cavity to prevent entry of cement particles into the acetabulum. This is the skin incision. This is the skin subcutaneous tissue facial lata. This is anterior to gluteus medius. This is TFL. With the underlying is the capsule. These are capsule and gluteus minimus muscle. This is the socket of the acetabulum. I am keeping the spike or the inferior edge of the acetabulum to expose the acetabulum. This is the acetabulum. This is the gluteus medius muscle which we have preserved. This is the socket. Now I am going to clear the soft tissue in the socket before keeping our processes. Taking out the tissue in the acetabulum. There should be no tissue or fragments in the acetabulum. You can see 360 degrees view of the acetabulum except for the posterior superior quadrant, which we can dissect if you do a THR. But this bipolar, for this bipolar, you don't need to dissect that posterior superior towards the posterior superior quadrant. Now our acetabular cavity is free. Now I am going to fill this with the mop. Which I will take out before setting the cement. We will encounter cement and embolism in a patient with decreased cardiopulmonary reserve. Always inform anesthetist while cementing. Wait for the cement until we get a doughy feel and then only take. Don't take it in liquid form. And using the syringe to inject the cement into the canal. And then I am going to pass the bipolar in a single go, gently. I am gently passing the stem while assistant is keeping the version. Keep some cement to the stem. And remove the excess cement. Move the mop, otherwise the mop will get stuck with the cement. The mop will come along with any excessive cement which might enter the acetabulum cavity. I have removed every cement particle. Now I am going to keep pressure and the assistant will give counter while the cement is getting set. This is the GT tip. I have kept my processes above the level of greater trochanter. I have slightly maintained a valgus in this case. After the cement is set, I am giving thorough wash and then I am going to reduce the same way as you reduce the tray. Make sure that there is nothing in the acetabular cavity. There should be no soft tissue and there should be no free fragments or cement particles in the acetabular cavity, as that will cause dislocation in our post-op period. Now I am going to reduce gently. You can appreciate the sound of our reduction. And if at all, if you suspect any soft tissue in between the socket and the acetabulum and the processes, you can gently do telescopic test or shuck test that will retract any soft tissue further away from our joint. After reducing, you should see for the lens which is adequately restored, and movements flexion, extension, abduction. There is no impingement. This is the external rotation 90 degrees. This is internal rotation 45 degrees. There is no instability in all these movements. Now I am going to close the wound. I am closing the capsule and the gluteus minimus muscles. After closing the capsulotomy, I am going to close the later. There is risk of injury of superior gluteal vessels and nerve in the proximal 5 centimeters of our incision above the greater trochanter. I didn't go too superior in this case, so we didn't encounter any bleeding. If we damage the superior gluteal nerve and vessels, there is chance of weakness of the denervation of the gluteus medius muscle that will dampen our purpose of saving it by going through this antero-lateral approach. So always make sure that you don't injure the superior gluteal nerve and vessels in this approach. This is the final skin closure. I am going to keep a compression dressing, and then I will make the patient walk on the same day.